Microneedling is one of the most requested procedures in aesthetics right now. It's also one of the most inconsistently performed. Wrong needle depth, misunderstood drug delivery, protocols built on habit rather than evidence, patients going through session after session with no meaningful result, not because the treatment doesn't work, but because the protocol was wrong from the start. Here's what we're doing today: a complete evidence-based breakdown of microneedling. How it works, how it should be done, what goes wrong, and what you need to know whether you're sitting in the chair or standing behind it. Let's get into it. What is microneedling? Microneedling, also called collagen induction therapy or CIT, is a minimally invasive procedure that uses fine needles, typically ranging from 0.25 mm to 2.5 mm in length, to create controlled microinjuries in the skin. These injuries are intentional. The goal is to trigger the skin's natural wound healing cascade, which activates growth factors, recruits fibroblasts, and stimulates the production of new collagen and elastin. The two main device types are the dermaroller, a manual rolling device, and the dermapen or motorized pen, which allows for more precise depth and speed control. Motorized pens are generally preferred in clinical settings for the simple reason that precision matters. The roller works, but the margin for error is higher, and consistency is harder to maintain across different facial zones. The mechanism is elegant. The complexity is entirely in the protocol. Mechanism of action. When the needle penetrates the skin, it passes through the epidermis and enters the dermis, at a depth determined by the device settings. That microinjury activates a three-phase healing cascade. Phase 1, inflammation. Immediately post-procedure, platelets release growth factors and cytokines. Think of this as the body deploying its repair team. Phase 2, proliferation. Fibroblasts, the cells responsible for collagen and elastin synthesis, are activated and begin producing new structural proteins. This phase unfolds over days. Phase 3, remodeling. New collagen fibers organize and mature. Skin becomes firmer, more even in texture, and scars become less pronounced. This phase can extend over several months. Here's the clinical implication. Visible results don't appear immediately. The remodeling that produces real change starts around week 4 post-treatment. One of the most common patient drop-off points is after session 2, because the skin doesn't look different yet. The biology tells a different story. Dropping out early means interrupting the cascade before it completes. Needle depth. Needle depth is one of the most critical variables in microneedling, and one of the most frequently mismanaged. Depth determines which skin layer you're targeting. Different layers, different outcomes. 0.25 mm to 0.5 mm* epidermal range. Used primarily for transdermal drug delivery enhancement and very superficial texture refinement. Minimal collagen stimulation at this depth. 0.5 mm to 1.0 mm* dermoepidermal junction. Appropriate for general skin quality improvement, texture, pore appearance, radiance. Good maintenance depth. 1.0 mm to 1.5 mm* superficial dermis. This is where meaningful collagen induction begins. Indicated for mild active acne, superficial pigmentation, early photoaging. 1.5 mm to 2.5 mm* deep dermis. Reserved for atrophic acne scars, old striae, and more advanced laxity. Requires proper skin preparation and a structured aftercare protocol. The critical error here is treating depth as a fixed setting. Applying 1.5 mm across an entire face for a routine maintenance session, or using 0.5 mm on a deep atrophic scar, are both clinical mismatches. Depth should be calibrated to the indication, the skin zone, and the patient's skin condition on that specific day. It's a clinical variable, not a default. Drug delivery. Drug delivery is where microneedling gets the most marketing hype and the most scientific nuance. The concept is straightforward. The microchannels created by the needles provide a temporary bypass of the skin's barrier function, enhancing the absorption of topically applied actives. The science supports this. with important qualifications. What the evidence shows: microchannels close within 15 to 30 minutes post-procedure. The absorption window is narrow and must be used immediately and intentionally. Molecular size matters significantly. High molecular weight hyaluronic acid, the form most commonly applied during microneedling, does not penetrate effectively even with open channels. Low molecular weight forms and fragments perform considerably better. Actives with strongest evidence for transdermal delivery via microneedling: stabilized vitamin C, ascorbic acid derivatives, encapsulated retinol, low molecular weight peptides, and platelet-rich plasma (PRP). What should not be applied during the open channel window: fragrances, alcohol, high concentration acids, or any potentially irritating compound. With the barrier temporarily compromised, the inflammatory response to these substances is amplified, the exact opposite of what you're aiming for. The clinical takeaway: drug delivery via microneedling works when the active is selected on the basis of molecular weight, evidence, and patient skin profile, not based on what's available on the clinic shelf. Protocol errors. Now the errors. They're more common than they should be. Error 1. Skipping Fitzpatrick assessment. Darker skin types, Fitzpatrick 4 through 6, have a significantly elevated risk of post-inflammatory hyperpigmentation following microneedling. Protocol should include a minimum of 30 days of preconditioning with depigmenting actives before the first session. Error 2. Insufficient inter-session interval. The minimum evidence-based interval between sessions is 21 to 28 days. This allows the remodeling phase to progress meaningfully. Weekly sessions don't accelerate results, they interrupt the healing cascade. Error 3. Treating active inflamed acne. Microneedling over actively inflamed acne lesions can spread bacteria and worsen the condition. The indication is post-acne scarring, not active grade 3 or 4 acne. Error 4. Excessive manual pressure with dermarollers. Heavy pressure with a roller increases effective depth unpredictably and creates inconsistent injury patterns. The correct technique is light, fluid passes, 4 to 6 times per direction per zone. Error 5. Inadequate patient aftercare instruction. If the patient leaves the clinic without clear written post-procedure instructions and applies makeup, goes to the gym, or has sun exposure the same day, outcomes are compromised and adverse event risk increases. Error 6. No topical anesthetic for deeper depths. For depths above 1 mm, topical anesthetic, EMLA or lidocaine cream, applied under occlusion for 30 to 45 minutes pre-procedure, is standard protocol. Without it, patient discomfort leads to inconsistent application and undermines the quality of the session. Aftercare. Aftercare is where the result is consolidated or lost. First 24 hours *. No makeup. 1. Intensive hydration with fragrance-free, alcohol-free, acid-free products. Physical SPF if sun exposure is unavoidable, but avoiding direct sun entirely is ideal. No gym, sauna, pool, or heat exposure. Gentle cleansing with lukewarm water. No scrubbing, no friction. 24 to 72 hours *. Mild flaking is normal. Do not exfoliate, do not pick. Redness and warmth are expected and indicate active repair inflammation. Continue intensive hydration. 72 hours to 7 days *. Resume SPF rigorously. Photosensitivity is elevated during remodeling. Avoid acids, high concentration retinol, and potent vitamin C until the skin barrier is fully restored. No additional ablative or exfoliating procedures during this window. For professionals the home care protocol prescribed post-microneedling is not supplementary. It's integral to the outcome. Clinical data consistently shows that structured post-procedure skincare routines meaningfully amplify final results. Indications and CONTRAINDICATIONS indicated for atrophic acne scars, post-inflammatory hyperpigmentation, photoaging with texture loss and early laxity. Striae, specific protocols apply. Enlarged pores. General improvement in skin quality and luminosity. Contraindicated in active, severely inflamed acne, active rosacea, active viral skin infection, herpes simplex being the most common risk, isotretinoin use within the past 6 months, impaired wound healing is a documented risk, keloid tendency. Microneedling can stimulate keloid formation in predisposed patients. Pregnancy and breastfeeding, precautionary. Patients on systemic anticoagulants. Individual clinical evaluation is non-negotiable. No generic protocol replaces a thorough patient history and skin assessment. Microneedling works. The evidence is solid, but outcomes are entirely protocol dependent. What you need to take from this: white heavy checkmark depth is a clinical variable, not a fixed default. White heavy checkmark drug delivery requires active selection based on molecular weight and evidence. White heavy checkmark 21 to 28 days minimum between sessions. Respect the biology. White heavy checkmark aftercare is part of the treatment, not optional. White heavy checkmark contraindications require individual evaluation every time. If you're a professional looking for structured, evidence-based protocols, I've put together a complete ebook on integrative aesthetic protocols. Link is in the description. If this breakdown was useful, a like helps this channel reach more professionals and informed patients. Drop any questions in the comments. I'll answer them. See you in the next one.